Today we're going to discuss how to build a team for a quality improvement project. At the end of this session, you'll be able to recognize the need for a multidisciplinary team with leaders and champions to carry out QI. You'll reflect on the principles behind using transformational leadership and the ability to enact QI. And we'll discuss the barriers and facilitators to change. And then we'll synthesize team composition and size recommended by IHI and reflect on QI examples of teams. So Maureen Bisogno, the CEO of IHI in 2012 said, "Everyone in healthcare should have two jobs, to do the work and to improve how the work is done." So forming a team is an important skill to know when you're conducting QI. It involves work across multiple systems and disciplines within a setting. It's the group of individuals within the healthcare charged with carrying out improvement efforts that report to either a CEO or a CNO. It's to be effective, it should include individuals representing all areas that will be affected by the improvement, as well as the patient or person. The team has to meet regularly to review performance data, identify areas in need of improvement, and carry out and monitor improvement efforts. Activities used include QI approaches and tools such as PDSA, which is Plan, Do, Study, Act cycles, workflow mapping, assessments, audit and feedback, benchmarking, and best practices. Forming a team is including the right people on a quality improvement project, and it's critical to the successful improvement effort. Teams vary in size and composition. Each organization builds teams to suit its own needs. First, you have to review the aim of the project. Second, consider the system that relates to the aim. What systems will be affected by the improvement effort? And third, to be sure that the team includes members familiar with all the different parts of the process, managers and administrators, as well as those who work in the process, including physicians, pharmacists, nurses, and frontline workers. And finally, each team needs an executive sponsor who will take responsibility for the success of the project. The team should have a clearly identified champion who's committed to the idea and process of continuous improvement. They need to be interested in building capacity in the practice for ongoing improvement and implementing effective processes that will enable the improvement. Processes may include gathering and reflecting on data, seeking out best practices or evidence, and engaging voices and perspectives of individuals involved in all aspects of the process or activity under scrutiny. The role of the QI team champion is to ensure that the team functions effectively and fulfills its charter for the organization. Who should be on a QI team? IHI recommends a team includes clinical leadership. This individual has the authority to change and to problem solve issues that arise in the process. This individual understands how the changes will affect the clinical care processes and the impact these changes may have on other parts of the organization. Also, someone with technical expertise. This individual has deep knowledge of the process or the area in question. A team may need several forms of technical expertise, including expertise in the QI process, health information technology, systems that need to support the proposed change, and specifics of the area of care affected. For example, a team implementing an intensive care management clinic for people with poorly controlled diabetes might need technical expertise in change management, the clinic's electronic health record, and the patient treatment protocols that will be used. IHI also recommends the team includes day-to-day leadership. This individual is the lead for the QI team and ensures completion of the team's tasks, such as data collection, analysis, and change implementation. This person must work well and closely with the other members of the team and understand the full impact of the team's activities on other parts of the organization, as well as the area they are targeting. Also, a project sponsor. This individual has executive authority and serves as the link to the QI team and the organization's senior management. Although this individual does not participate on a daily basis with the team, he or she may join periodically and stays apprised of its progress. When needed, this member can assist the team in obtaining resources and overcoming barriers encountered when implementing improvements. IHI recommends the team size. The optimal is between 5 to 8 individuals. This may vary by practice. Most important requirement is not size, but diversity of the participants. It's important that the team includes a diverse group of individuals who have different roles and perspectives on the patient care or other processes under consideration. This group should include, whenever possible, input from the end user of healthcare, the patient. So IHI potential team members include the CEO, medical directors, physicians, nursing staff, PAs, MAs, patient representatives, operations managers or directors, health educators, patients, community health workers, peer mentors, community representatives, directors of clinical services, practice managers, medical records staff, receptionists, physical plant operations, lab techs, case or care managers, billing department staff, pharmacy or dispensary staff, or possibly a finance director. Here are the top 10 barriers to change. The first one is confusing strategies. It's unclear what the organizational strategies are, and there are too many priorities. The second one is over-controlling leadership. A perception we do not have the trust and freedom to create change from the bottom up. The third is one-way communication. Leaders do not communicate with staff, or not enough in informal ways of connecting with creative people. The fourth is poor workforce planning. The perception of not enough time. Is this an inappropriate skill mix or skills deficit from not nurturing staff? The fifth barrier is shifting innovation. There's no shortage of ideas, but a shortage of processes to capture ideas. The sixth barrier is playing it safe. It's too difficult to access support for ideas and fear of doing something new. The seventh barrier is poor project management, a tendency to value inputs and action rather than to value outcomes. We underestimate the complexity in which we are working. The eighth barrier is undervaluing staff. They often do not feel like we have staff often do not feel they have a real stake in the organization's future, or that they're a cog in the engine rather than a value-added individual. The ninth barrier is inhibiting environment, where the physical environment can stop people meeting together, or IT system that does not help access knowledge and share information. And the 10th barrier to change is the perceived incentives. If better outcomes for patients are a loss of income, then of course it's a disincentive to change. So here are some building blocks for change. The first is inspiring and supportive leadership, taking forward ideas based on quality. Distributed leadership where people are trusted and talent is nurtured. The second building block for change is collaborative working. Peer collaboration nurtures a positive mindset and desire to drive bottom-up change. The third building block is flexibility and adaptability. The need for flexibility in our formal organizations and in day-to-day processes. The fourth building block for change is smart use of resources to deliver change within the current means. And the fifth building block for change is autonomy and trust. Increasing a sense of trust gives people the confidence and permission to deliver change and removes the fear associated with failure. It fosters a culture of reflection and learning on what works and what does not work. The sixth building block for change is challenging the status quo, where you nurture and embrace the creativity of all the staff to challenge the status quo and deliver real change. The seventh building block for change is a call to action. Clear articulation of the organization's purpose and meaning to inspire bottom-up contributions to the mission. The eighth building block for change is fostering an open culture with transparency and openness, a more positive environment. The more open an organization is, the more innovative it is. The ninth building block for change is nurturing people, prioritizing training and development. The 10th building block for change is seeing the bigger picture. Give staff space and freedom to develop long-term improvement plans. And the 11th building block for change is thought diversity, where you value dissenting opinions and that give more effective change. So here's some different types of leadership within quality improvement. Transactional leadership is an exchange based on relationship where self-interest is dominant. Transactional leaders adhere to set rules and regulations, motivating employees with specific task-based rewards. Whereas transformational leadership is the ability to motivate and to encourage intellectual stimulation through inspiration. Transformational leaders aim to lead by example, encouraging employees to follow a set of values rather than a rule book. So transformational leaders spend time teaching and coaching. They emphasize employee training and development. They also focus on building a value-led work culture. Employees work hard not because they seek reward, but because they believe it's the right thing to do. They also show employees that they're trusted, giving them the authority to make decisions and equipping them with the ability to make good decisions by providing thorough and ongoing training. Transformational leaders do not micromanage employees. They avoid performance-based rewards and adopt a holistic approach to discipline. And the workers are intelligent adults who are treated that way. Transformational leaders give employees the bigger picture rather than presenting them with a series of small targets. They show them where the trust is heading as a whole, demonstrating how work is contributing to success. So here's an example of improving care in an office practice. The aim is to improve care for all patients with chronic disease by making improvements in the clinic that impact the 6 dimensions of quality as outlined in the Institute of Medicine Crossing the Quality Chasm. Here's the team. A technical expert, MD physician at a downtown clinic. The day-to-day leader is the RN manager of the downtown clinic. Additional members are our patient educator, the MA, the clerk and scheduler, lab manager, and QA expert. And the sponsor is the medical director in the primary care practice. Here's another example of a team in improving patient safety. The aim is to reduce adverse drug events on all med-surg units by 75% within 11 months. The team included the clinical leader, MD chair, pharmacy, and tech committee, and a patient safety officer. Technical expertise came from the pharmacist and the director of the clinical pharmacy. Day-to-day leadership came from the RN manager on the med-surg unit. Additional members were risk manager, QI specialist, a staff nurse, staff educator, and information technology. The sponsor was the MD CMO. And here's a third example of a team to improving clinical care. The aim of this project was to redesign the leadership and care systems in the medical intensive care unit in order to reduce harm and improve outcomes for patients. The team included a clinical leader, an MD medical director, and medical intensive care unit. The technical expert was the MD and intensivist. The day-to-day leader was the RN MICU manager. Additional team members were RT, QI specialist, staff nurse, clinical pharmacist, and CNS. And the sponsor was the MD COO. And here's a fourth team example to improve workflow. To ensure that the aim of this project was to ensure that patients receive timely access to appropriate care in the hospital and move through the system efficiently. So, starting in the ED department, the team included the clinical leader, which was the medical director, with technical expertise from the director or nurse manager. Day-to-day leadership came from a frontline nurse. 2 continuity staff with a cross-organization view of flow, which included operation engineer or vice president and management responsibilities across departments and services were thought to also be needed to examine work over time. The ICU team included the clinical leader, intensivist or medical director, where the technical expertise was the director or nurse manager, and day-to-day again was frontline nurses. And the 2 continuity staff were important here. As you can see in this example, it was important to have 2 teams, one in the ED, which was sending patients into the system, and one in ICU, which was receiving patients from the ED. This is very common when you're examining workflow, particularly with transitions of care. This one also involved adding an OR team because many of the patients went from the ED to the OR before they went to ICU. So you can see here, the team in the OR included a clinical leader, a surgeon or anesthesiologist, where the tech expert was the director of manager of surgical services, and the day-to-day leader was the OR nurse. And surgery techs were added. There was also discussion of the continuity staff, and the project sponsor for this was the CEO, as this had tremendous financial impact. So, as you can see, building a team to promote teamwork is very important whenever you're undertaking quality improvement. Thank you. So, the assignment for this week is to think about the following elements of teamwork, complete the worksheet as assigned, and remember QI is an iterative process and your worksheet may change as you learn new or additional information or find new evidence. So, this week what you're going to do is to take your worksheet and complete your assignment. Focus on the implementation team that has special expertise regarding the program being implemented using implementation science and practice and improvement cycles and organizational system change methods. Decide who will be on your team. 3 to 5 people, and consider the following. Can you repurpose an existing team, or do you need to develop a new team? And what are the core competencies you need on your team? Consider members within your organization as well as strategic partners from outside. Include members who are flexible and adaptive to change, know the new intervention, know implementation science, work on multiple system levels and see the big picture, and practice the PDSA cycle, usability testing, and effective communication processes. All you have to do is complete the lesson on your worksheet. Thank you for listening, and if you have any questions, please email me.